the refractory angina, various attempts has been made to define refractory angina. But the definition described in 2019 by ESC has been well accepted, which states chronic angina of more than 3 months duration in the setting of obstructive coronary artery disease, which can't be controlled by combination of optimal and escalated GDMT or angioplasty or CABG, and where reversible myocardial ischemia has been established to be the cause of angina, and objective evidence of reversible ischemia has been demonstrated by exercise, pharmacological stress test, or by imaging of the coronary physiology. But it has some limitations of this definition due to lack of proper epidemiological data in the etiopathogenesis of the refractory angina. The following has been excluded in the true definition of refractory angina. One is absence of obstructive coronary artery disease, coronary vasospasm, that is premetal angina, coronary microvascular dysfunction. Although these may coexist with obstructive CAD, the term refractory angina is preferred over other synonyms, that is end-stage CAD or intractable angina. This is some of the few epidemiological studies indicating the incidence of refractory angina and their common substrates. Overview of this reveals about 5 to 10% may have a refractory angina even after GDMT or successful revascularization. Although mortality is modest, but pain is more severe than usual stable angina, and pain begets pain, ultimately landing in a chronic chest pain syndrome with practically no option. And there is a progressive decline in the quality of life, so there is an unmet need for symptom control. Regarding the etiopathogenesis of refractory angina, chronic total occlusion constitutes the commonest substrate, and it occurs in about 60 to 65% cases as found in various studies. Others are being not amenable to revascularization, diffuse disease, failure of previous CABG, PTCA, comorbidity, advanced age, lack of graft condi for CABG, impaired LV function, and suboptimal response to conventional therapy. The pathophysiology of refractory angina is not very different from the chronic stable angina, as it also has the basis of ischemia-centered angina paradigm, that is critical coronary stenosis leads to oxygen demand-supply mismatch and tissue-level activation of nociceptive fibers and pain perception. But this paradigm has been challenged as there may be some ischemia in absence of angina, the so-called silent myocardial ischemia, as evidence in Holter monitoring tracing or stress test with asymptomatic ST depression. There may be, on the other hand, there may be angina without ischemia, the so-called sensitive heart. Again, we may have 30% AMI which are painless, and 70% episodes of myocardial ischemia in CAD is asymptomatic. So, ischemia does not correlate with angina. It is a complex interplay between the anatomical substrate to the perception of pain. So, what is the anatomical substrate? In stable angina, we see that it is the critical coronary stenosis, superadded with inflammation and platelet dysfunction. But in case of refractory angina, practically there is no option in this regard. But there are other conditions like endothelial dysfunction, microvascular dysfunction, and vasomotor dysfunction also contribute in a great extent to the development of refractory angina. But as it has no definite data and it is very difficult to assess its contribution to development of refractory angina, the ESC has excluded these entities from the true definition of refractory angina. But in spite of that, we have to consider these entities. The other aspect being the perception of pain. So this is also an important aspect, especially with reference to refractory angina, where the anatomical subtext is very difficult to correct as it has reached almost the end stage. So this perception includes heart-brain axis, nociception and neuromodulation. So ischemia is not synonymous with the critical stenosis of epicardial artery. It involves greatly in the perception of pain and its neuromodulation. So for perception of pain, brain has to meet with the heart, and this starts with nociception at the end of free nerve endings, and the angina is perceived only if it reaches the sensory cortex. The hypoperfusion-induced ischemia, there is liberation of the neurotransmitters, induction of neurotransmitter and induction of the pain sensation, which is aggravated by ischemia-derived less ATP, ADP and AMP. So there is sensation of pain, in the cardiac pain. And these pain sensation is being transmitted through vanilloid receptors, afferent fibers in the sympathetic root ganglion, thalamus, sensory cortex, and ultimately there is perception. And this transmission line may have some peripheral and the central neuromodulation, and ultimately it offers some modification of the afferent pain signals among the neural and the non-neural cells. And this forms the basis of painless ischemia on one hand and sensitive heart, that is angina without ischemia on the other hand. So neuromodulation is an important aspect in refractory angina. In modifying the angina, it can modify by myocyte metabolic milieu, can be modified by interfering pain neurotransmitter, can be interfering, there may be interfering transmission via the afferent sympathetic and the vagal fibers, and getting of transmission at the thalamic level. And these concepts are very important as they are the principles of emerging therapy in pain control in refractory angina. Another important aspect is coronary microcirculation, which also influenced by several factors, that is intraventricular RA and coronary sinus pressure, and increased coronary sinus pressure improves redistribution of blood in ischemic territory. Diastolic augmentation also improves the coronary circulation, as well as neurovascular also improves and ultimately it improves the refractory angina. Similarly, metabolic adaptive response may also influence the refractory angina by changing the metabolic milieu. So, to conclude, the pathophysiology of refractory angina is a very complex process. We generally evolve around advanced coronary artery disease or fixed epicardial coronary artery stenosis. But this only forms a tip of the iceberg. There are multiple factors, that is microvascular dysfunction, neurogenic dysfunction, vasospastic angina, mitochondrial dysfunction, and even the psychologic dysfunction may contribute to development of hypoperfusion. And this hypoperfusion may translate into overt ischemia, and this ischemia may stimulate at the tissue level, spinal cord level, and the brain level to modify the perception of angina. So, with this advanced knowledge of pathophysiology, there are some emerging therapies and making the refractory angina from a no option entity to few option. And these there are only targeting at the stimulation of the nerve and the spinal cord system, as well as improving the microcirculation, which will be probably deal with my next speakers. Thank you for patience listening. Thank you, sir.